Again, I apologize about my tardiness. Okay. So chapter 14 is one of my favorites. I know I feel like I say that almost every time you guys hear my voice, but really chapter 14 gets into some really interesting facts about the spinal cord. We're going to learn a little about reflexes, kind of review some concepts that we first saw all the way back in chapter 1. So again, that's why I always tell folks one of the most important chapters in bio 210 and 211 is chapter 1, because it gives a nice broad overview, the overall concepts between anatomy and physiology. And a lot of those concepts run throughout all of these different systems that we're studying. So let's talk about the spinal cord. All right, one of the parts of the central nervous system. It essentially is going to connect, all right, the brain, the other part of your central nervous system, to the rest of your body. And so it's kind of like a highway, so to speak. You got traffic going in both directions. You have sensory input coming from the body, carrying sensory information up to the brain. And then you have motor output, which is going to send motor commands from the brain out to the rest of your body. Now, the latter part of today's chapter, we will go into the spinal reflexes. And so we're going to talk about, well, one, the different types of reflexes, and then we're going to specifically talk about spinal reflexes, because they're just that. They're spinal reflexes, which mean it does not involve the brain. So when we're learning about these different pathways for reflexes, this one here will not include the brain. And it's nice because it makes it that much faster. And sometimes when we're dealing with reflexes, it could be, in some situations, a life or death situation, but most of all, just preventing significant damage done to yourself. So we'll go over that. All right, so I really think that this is one of my favorite pictures for this chapter, because it does show you, all right, the importance of understanding the anatomy and physiology of the spinal cord, and also spinal roots and spinal nerves. Now, keep in mind, a spinal nerve is a nerve that comes off of the spinal cord. In lab today, we're going to talk about the cranial nerves, and cranial nerves are nerves that come off of the brain. So when we're talking about a spinal nerve, we're talking about this area, this structure right here. That's your spinal nerve. And we'll see that the spinal nerve kind of splits off, okay, to two different structures, one in the posterior part back here, and one in the anterior portion up here. And those are called spinal roots. So the ones in the front, obviously, are going to be the anterior roots. And they carry motor information only. We're only going to see motor axons in the anterior root. In the posterior portion there, the posterior root, it's only going to contain sensory axons. That means it's only going to carry sensory information. So you've heard me say before, the motor in most cars are in the front. So motor axons will be in the front, in the anterior roots. Sensory axons will be in the posterior root. Notice there's another structure here called the posterior root ganglion. That's this little bulge-like structure here. And in this posterior root ganglion, also known as the dorsal root ganglion, that's where we're going to see the cell bodies of our sensory axons, right? Of our sensory neurons, right? The cell body to these sensory neurons are going to be located in the posterior root ganglion. Because what is a ganglia? A ganglia is a cluster of cell bodies in the peripheral nervous system. So a nucleus is a cluster of cell bodies, but we find that in the central nervous system. So we're going to go over the different types of sensory receptors, more so in chapter 16, but we'll give you just a broad overview. And then we're already pretty familiar with our effectors. All right, so when we're dealing here with our spinal cord, we're going to have two types of sensory receptors, our somatic and the visceral. And then for the effectors, we're going to have two types of effectors. We're going to have our visceral, also known as the autonomic, and then somatic. So we'll talk about this in a little bit more detail here. All right, So when we're, hold on one second. Okay, good. When we're going, the first part of class tonight, we're going to be talking about our conduction pathways. And these are these spinal pathways that go up and down the spinal cord. And it depends on which pathway we're going to be discussing is going to determine the type of function and information that it carries. So for example, our spinal pathways, there's two types, sensory or motor, that's it. So for a general rule, your sensory pathways are going to carry sensory input from your brain, from your body, the periphery, up to your brain. So our sensory pathways are also known as ascending pathways because that sensory input ascends up to the brain. The other type of pathways are conduction pathways are motor pathways. And so they're going to carry motor command information from your brain down to the periphery. So these conduction pathways are also known as descending pathways, and they carry motor commands. So they're going to essentially control the effectors. Remember, when we're talking about our homeostasis mechanism there, receptor control center effector, we're going to really see that in a little bit more detail now when we're talking about reflexes and these conduction pathways here. So a couple common characteristics that these conduction pathways have is all pathways are paired. Okay, that means we're going to have a left track and a right track. Now, the cell locations for these pathways are going to be located in a couple different areas here. So let's talk about that. All right, the axons, we all know what an axon is, all right, are going to be found in the spinal cord tracts. And I'll show you this here as we move through the chapter. Okay, so right now, the axons are going to be found in the spinal cord tracts. For our cell bodies, we have three areas that we can find cell bodies. You know, cell bodies are going to cluster, right? So we're going to see them in the ganglia, for example, that dorsal or that posterior root ganglia. We'll also see these cell bodies in the spinal gray horns. So what is the spinal gray horn? All right, here. This is the posterior gray horn. This is the anterior gray horn in the front. And then we have our lateral gray horn. We'll go over this more in detail in lab. Okay, so if you don't have a great understanding of it now, don't worry, we will go over this in detail, where the horns are and all that. Okay, but that's the spinal gray horns. And then the third location for our cell bodies will be in the gray matter of the brain. So that includes the cerebral cortex and any nuclei that we may see up in the brain. All right, so each pathway is going to be made up of a chain of 2 or more neurons, a minimum of 2, but you could have 3, you could have 4. All right, so these pathways will be made up of a chain of 2 or more neurons. Now, most of these pathways, notice I didn't say all. Most of these pathways are going to cross over. We call that decussation. They'll cross from the right side to the left side and vice versa. Basically, we're going to cross over the midline here. So basically, this is what we talked about in chapter 13, how the right cerebral hemisphere will get input from the left side of your body. And that's what's going to happen here. All right, your brain is going to process information that comes from what we call the contralateral side, which is the opposite side. Now, some of these pathways don't cross. They stay on the same side. So we refer to those as ipsilateral. All right, but most will cross. All right, so let's start off with our sensory pathways. I want to talk about the sensory pathways, and then we'll go into the motor pathways. So the sensory pathways are going to start off in the periphery, and then they're going to transmit sensory input up into the spinal cord, and then eventually up into the brain there. So we're going to start off, all right, with what we call our general sense receptors, which are located out in the periphery. So there's a couple different types of these general sense receptors, right? We have somatic sensory and visceral sensory. So we break down the somatic sensory into our tactile receptors. And if you're not familiar with tactile, that's touch, okay? So the feel, so when we talk about the characteristics of an object, what we're meaning is it soft? Is it furry? Is it hard? Is it round? Is it sharp? Okay, that's what we're talking about when we're dealing with tactile receptors. Proprioceptors are going to be these specialized receptors. They're going to be found in the joints and also in the muscles and tendons of these joints. Sometimes they're referred to as mechanoreceptors, but basically they provide sensory input to the brain and spinal cord, and they tell those structures what that joint is doing. If that joint is flexing, extending, abducting, adducting, all right? Basically, when we talk about stretch, right, what we're really meaning is we're going to be moving these tissues that make up these joints. We have these special receptors that are in those tissues, and those receptors pick up on that movement, that stretch that's occurring. So that those receptors will tell your brain the exact location of that joint, what it's doing. For example, is your elbow flexed at 90 degrees? Is your arm extended at 110 degrees? Okay, these are all this information will be transmitted to the brain through these proprioceptors, picking up that stimuli information. The other type, all right, of sensory receptors are what we call visceral sensory receptors. Okay, so visceral, think of viscera, think of organs. And so they're going to detect certain information in certain organs like your stomach, some of your blood vessels, heart, anything. So they're going to detect changes. And one of the examples that we give here is stretch. For example, the stomach. When you start to drink and eat substances, it starts to fill your stomach up. It puts pressure on the stomach walls and it stretches those walls slightly. Well, the receptors in those walls then send information up to your central nervous system, and it says, hey, there's food and liquid in the stomach. We need to start the digestion process. And that's what happens, right? Your stomach will then start to become more motile. It'll start to move the substances around. You'll start to produce gastric juices, for example, hydrochloric acid. So we can start to break down that food and liquid, okay, as the digestive process occurs. We'll talk more about it. You're going to learn all that information. Well, anything having to do with the digestive system is in Bio 211. But we'll talk more about this throughout the rest of the course here. All right, so let's start off with our sensory pathways here. So remember what I was saying, we have two types, the somatosensory and the visceral sensory. So think of the somatosensory, that's going to be information that you can pretty much consciously perceive. So that signal information will originate either in the skin or in the muscles or in the joints. Remember what we said for somatosensory pathways. It'll be, we have those tactile receptors, and those are located all over the place, predominantly in the skin. And then we have our proprioceptors, and those are going to be primarily in the joints there and the muscles of those joints. And then the other type of visceral sensory pathways are going to be the pathways that are going to carry sensory input from the viscera. You're going to learn more about this pathway, or these pathways, I should say, in Bio 211. All right, but all of these pathways are going to be based off of the information that I'm going to teach you tonight, or that I'm going to discuss with you tonight. All right, we're going to start off with a stimulus of some sort, and we're going to have a receptor there to pick up that stimulus information and transmit it up to the central nervous system. And then you're going to learn, all right, how that information gets up there. And then we'll talk about how motor information leaves the sensory nervous system and goes out to the effector. All right, so with our sensory pathways, okay, remember what we said, we have a chain of neurons, at least two or more. So in this, when we're talking about these sensory pathways, most of them will have three, right? We're going to talk about one that has two here shortly. All right, so we have, for example, we're talking about the series of neurons. The first neuron we call the primary neuron. All right, some folks refer to it as first order. I really don't. Then obviously the second neuron will be the secondary neuron. The third neuron will be the tertiary neuron. So you're going to see some patterns start to develop here that you're going to apply to a lot of these sensory pathways. Pretty much the primary neuron, its peripheral nerve ending is going to be receiving that sensory input from the receptor. So we're going to see that pretty much every single time with the primary neuron. Peripheral ending in the skin, let's say, or it could be in your knee joint, for example, and it's going to send that information, all right, up to the spinal cord. Now, the cell body of that primary neuron is going to be found in that posterior root ganglion, right, or the dorsal root ganglion. And we saw that that's close to the spinal cord. And then, all right, the axon for that primary neuron is going to then head towards the secondary neuron and synapse on the secondary neuron. Now, the location of the secondary neuron will vary, right, depending on what pathway we're talking about here. And I'll discuss that in more detail for each specific pathway. So the secondary neuron we consider to be an interneuron. It's going to receive that sensory input from the primary neuron, and essentially it's going to just transmit that information onwards to the tertiary neuron. So the tertiary neuron most times will be found in the thalamus, for example, but sometimes we don't go to the thalamus. Instead, we might go to the cerebellum, and that might be the end of that specific sensory pathway. And we'll discuss that because that's true. Sometimes we just have two neurons in our chain. All right, if we're not going to the cerebellum, our secondary neuron is going to synapse onto the tertiary neuron. And that tertiary neuron is going to transmit that sensory input to our somatosensory cortex, right? Obviously located in the parietal lobe. And we call that the primary somatosensory cortex right there. All right, that is found in the post-central gyrus. Okay, your somatosensory cortex is located in the post-central gyrus. So this is just an overall kind of example of what we're going to be looking at here. So we're going to start off with our primary neuron, and our nerve, the receptor is somewhere here in the periphery, your fingertip, your knee, your toe, whatever. So it's going to get that sensory information. It's going to transmit it along the peripheral ending here. Here's our cell body in our posterior root ganglion. It'll then enter into the spinal cord. Since it's sensory information, it's going to enter in through the sense of the posterior root here. It enters into the spinal cord, and then it's going to synapse onto our secondary neuron. And like I said, the secondary neuron could be in the spinal cord, or it could be located elsewhere in the brainstem, for example. And I'll show you some examples there. And then that secondary neuron ascends up towards the thalamus here. And it'll synapse onto the tertiary neuron in the thalamus, and the tertiary neuron will then go to the somatosensory cortex somewhere in the parietal lobe there, okay, in the post-central gyrus. All right, that's just a kind of a general overview, all right, of a sensory pathway. Okay, so let's start off with a specific sensory pathway. Right, we call it the medial lemniscal pathway. And the medial lemniscal pathway involves this structure here called the posterior funiculus. So what is the posterior funiculus? I'll show you. Wait a minute. I don't even have to go that far. Here's the posterior funiculus right back here. All this white matter in the spinal cord is called the posterior funiculus. All this white matter here in the front is called the anterior funiculus. And then all of this white matter here on the side is the lateral funiculus. Right, so when we're talking about our posterior funiculus, that's the specific portion of the spinal cord that we're going to see our primary neuron traveling. Right, if you recall, the medial lemniscal pathway was going to be found in the brain stem. The medial lemniscus was a structure that I was showing you folks, found in the midbrain, the pons, and the medulla oblongata. And medial lemniscal pathway is just myelinated tissue. It's white matter. It's myelinated axons, okay? And so it's going to be found in the brainstem. So let's start off real simple. So this pathway, the medial lemniscal pathway, is going to carry proprioception, touch, pressure, and vibration. You need to know what sensations or what sensory input that this pathway carries. So it's proprioception, touch, pressure, and vibration. And it's going to use 3 neurons to do this. So our primary neuron starts off in the periphery. Where is that? In the skin. And it's going to travel all the way to the brainstem. So it's not going to synapse in the spinal cord. Okay, the primary neuron is going to synapse on the secondary neuron in our brainstem. But we'll get to that in a second. All right, so the peripheral receptor, all right, is going to be, let's use the finger, for example. Your peripheral receptor is in the finger. That becomes stimulated, and it's going to then transmit that sensory input on that primary neuron, first down the axon. It'll enter into the spinal nerve, and then it'll enter into your spinal cord through the posterior root. It enters then eventually into the spinal cord specifically. So now it has 2 choices. This primary neuron is going to, yes, travel in the posterior funiculus, but the posterior funiculus has 2 regions there. Well, actually 4, because you have 2 on the left and 2 on the right. But in the posterior funiculus, you break down the posterior funiculus into what we call the Fasciculus cuneatus or the Fasciculus Gracilis. I'm going to show you a picture real fast here, just so you know what I'm talking about. So here's our primary neuron, okay? So it's getting information somewhere from the periphery there, okay? Here's the cell body for that primary neuron in the dorsal root ganglion. So that axon then enters into the spinal cord through the posterior root because it's carrying sensory information, and only sensory neurons are found in the posterior root. It then will enter into the spinal cord, and it's going to travel in the posterior funiculus in either what we call the Fasciculus Gracilis, which is the green structure, or the Fasciculus cuneatus. And it depends on where that information is coming from. If it's coming from your lower extremities or the lower portion of your trunk, that sensory input will travel on the Fasciculus Gracilis. Easy way to remember that, y'all, is remember the gracilis muscle? It's one of the muscles in the medial compartment of your thigh, okay? Easy way to remember. Right, that's in your lower extremity. So the Fasciculus Gracilis is going to carry that information from the lower extremities in the lower portion of your trunk there. So that information is coming from your hand, then it's going to travel in the Fasciculus cuneatus. Point being is that primary neuron will then enter in, depending on where it's coming from, into either one of these fasciculi, and it's going to ascend up to the brainstem. All right, more on that in a second. All right, so like I said, that axon enters into the posterior funiculus, and it will specifically go either into the Fasciculus cuneatus or the Fasciculus gracilis, depending on what part of the body it's coming from. And it ascends up the spinal cord into the medulla oblongata. And then that is where it's going to synapse or contact our secondary neuron. So our secondary neuron, that's our inner neuron. It's going to transmit that sensory input from the primary neuron to the secondary neuron. So it's going to relay that information from the medulla oblongata all the way up to the thalamus. So this is what we're going to see here in our secondary neuron. All right, so here's our primary neuron. It's ascending up through the spinal cord, up into your brainstem. And it's going to arrive and synapse on the secondary neuron. Now you can see here, we have the nucleus gracilis and the nucleus cuneatus. So again, like I said, depending on the origin of the stimuli is going to determine, all right, which nucleus it's going to go into. If it is carrying information from your lower extremity, it's going to synapse on the secondary neuron in the nucleus gracilis. If it's carrying information from your upper extremity, then it's going to synapse here in the nucleus cuneatus. So in this drawing here, it's the nucleus gracilis. So the primary neuron is going to synapse on that secondary neuron in the nucleus gracilis here. That secondary neuron is going to decussate. It's going to cross over. And it does so before it enters into that medial lemniscal pathway. Once it decussates and it enters into the medial lemniscus, it's going to ascend up from the medulla oblongata through the pons. The whole time it's traveling in the medial lemniscus up through the midbrain all the way up here to the thalamus, where it's going to synapse onto our tertiary neuron. So let's go back to the previous slide here. Okay. So like I said, the cell body is located in one of those nuclei, either the cuneatus or the gracilis. And that's where the primary neuron is going to contact or synapse onto our secondary neuron. Then that secondary neuron decussates, it crosses over, and it enters into that medial lemniscal pathway, and it ascends all the way up to the thalamus until it synapses onto our tertiary neuron. And then from there, our tertiary neuron is going to relay that sensory inputs to the appropriate area in the primary somatosensory cortex of the parietal lobe. Remember, it's got to go to the appropriate area so your brain knows where that input is coming from. Remember that sensory homunculus that we learned about, that really kind of freaky drawing there? Well, it's going to go into a specific area there. Then your brain realizes, oh, okay, I am feeling something vibrating on my leg, okay? Or I feel something vibrating in my hand, like my phone is in my pockets and I feel it vibrating, and that is the medial lemniscal pathway allowing us to feel the vibration. All right, so here we can see, last part, our secondary neuron ascending up through the brainstem here to the thalamus, and then from the thalamus it goes to the primary somatosensory cortex. All right, and then that's when you come to conscious realization of whatever that stimulus was. All right, our next sensory pathway is what we call the anterior lateral pathway. This pathway carries more touch sensation, but in this case it's crude touch. All right, also some pressure, pain, that's a big one, and temperature. So again, we're going to use our 3-neuron chain. So you're going to see some similarities, okay, between this pathway and the previous pathway. For example, the primary neuron always starts in the periphery. So it's going to carry that sensory input from the skin, all right, to the spinal cord. Now the medial lemniscal pathway, all right, the primary neuron didn't synapse on the secondary neuron until it got to the brainstem. Different story here. All right, so the axon of that primary neuron is going to enter into the spinal nerve, enter into the posterior roots, and then it's going to find its way into the posterior horn of the spinal cord, where it's going to synapse onto our secondary neuron. So real quick here. Actually, I'll come back to that one in a second. Let me show you on this one's a little bit easier. All right, just a quick review. Here's the posterior horn. So that primary neuron is going to enter in and synapse on the secondary neuron here in the primary horn. That's what this drawing is showing you. I just didn't want to confuse you because there's two primary neurons in this picture, and I'll talk about that in a second. All right, but the point being is that primary neuron enters in and it's going to synapse onto the secondary neuron here in the spinal cord, not in the brainstem. Spinal cord. All right, so once that synapse occurs, that secondary neuron, okay, is going to ascend up through the spinal cord all the way to the thalamus. Remember, our secondary neuron is an inner neuron, but don't forget, it's got to cross over. And so in this case, what we're going to see is we're going to see that secondary neuron decussate, and it's going to ascend in what we call the contralateral white matter on the other side of the spinal cord. And so here, it's either going to go, it's going to ascend either in the lateral spinal thalamic tract or the anterior spinal thalamic tract. All right, either or. And then from there, all right, it gets to the thalamus, and you know the rest of the story, okay? That secondary neuron will then synapse onto the tertiary neuron, and that tertiary neuron is going to relay that sensory input from the thalamus to the appropriate region of the cerebral cortex. Where is that located? In the somatosensory cortex, which is the post-central gyrus of the parietal lobe. So let's take a look. Okay, here's that primary neuron. It's going to carry that sensory input from the periphery. It's going to enter in through the spinal nerve, and then it's going to enter into the spinal cord through the back, through the posterior roots, and then it's going to synapse onto the secondary neuron in the posterior gray horn here. Then that secondary neuron is going to decussate. It's going to cross over. And so it's either going to ascend up through the spinal cord, through our anterior spinal thalamic tract, or the lateral spinal thalamic tract. Look at the name, spinothalamic. It's telling you where it's coming from and where it's going to. Spinal cord to the thalamus. So it ascends all the way up. That secondary neuron travels through the brainstem, and it ascends all the way up here to the thalamus, where it will synapse onto the tertiary neuron. And you know the rest of the story. The tertiary neuron carries that sensory input to the appropriate cerebral cortex, to the appropriate region of the cerebral cortex. And again, this is another tract where we see decussation. It crosses over, and we have 3 neurons in that chain there. All right. The next sensory pathway is called the spinocerebellar pathway. Take a look at the name. Spino is going to be from the spinal cord to the cerebellum. Now, this one only utilizes 2 neurons. 2 neurons, okay? But similar type of scenario here. That primary neuron, okay, that primary neuron is going to start off in the periphery, and it's going to travel to the spinal cord. So same story, okay? The axon will enter into the spinal nerve, enter into the spinal cord through that posterior root, and then it's here in the spinal cord where that primary neuron is going to synapse onto the secondary neuron in the posterior horn. So that was very similar to what we just saw, okay, with our anterior spinal thalamic tract and the lateral spinal thalamic tract. We saw a very similar type of situation with the primary neuron and the secondary neuron. Now where we deviate from that is where the secondary neuron is going to travel into the cerebellum. So here is a little bit of a catch for you, right? This pathway, some of the axons are going to cross over, some of them remain ipsilateral, which means they stay on the same side. Okay, so some can cross, and some will remain ipsilateral. All right, I'll show you that here in a picture here. So we have two spinal cerebellar pathways. We have an anterior spinal cerebellar pathway and a posterior spinal cerebellar pathway. Point is, the secondary neuron, all right, will always end up in the cerebellum. It just depends if it's going to stay on the ipsilateral side or the contralateral side. So that's what we're seeing here in this drawing. Okay, so here you can see our primary neuron entering in. All right, it's going to then synapse here onto the secondary neuron, and that secondary neuron is going to then ascend up through the brainstem, and it's going to get to the pons here, for example, and you can see how some will stay ipsilateral and some will cross over. We'll also see here how our primary neuron enters in, synapses onto a secondary neuron, and then it decussates right at the spinal cord level. And then it ascends up to the brainstem here and into the cerebellum. So some start off contralateral, and some of those tracts will remain ipsilateral. Keep in mind, when we're dealing with the spinal cerebellar pathway, we're dealing with proprioceptive information. We talked about that in chapter 13, how much of a big influence the cerebellum has on proprioception. Proprioception helps with balance, equilibrium, posture, and whatnot. Okay, so that's for our sensory pathways. Let's talk about our motor pathways. So we talked about the first part of that homeostatic control system that we discussed way back in chapter 1. Talked about a receptor, control center, and effector. Well, the sensory pathways only talk about the first part, which is usually the receptor and the control center. Now we're going to talk about the remaining parts, right? We're dealing with motor pathways. Now we're going to include an effector into this. So in this case, all right, with some of our motor pathways, right, our effectors are either going to be a muscle or gland, right? But we're going to deal with our effectors in Bio 210. Our effectors are going to be skeletal muscles. In Bio 211, you're going to be talking much more about the glandular effectors and smooth muscle and cardiac effector tissues. Okay, so right now we're just going to deal with the somatic skeletal muscle effectors. So when we're dealing with motor pathways, we're going to have at least 2 neurons. You can have more, but we're going to have at least 2. So if we're dealing with just 2, right, we have what is called an upper motor neuron, and we have a lower motor neuron. So our upper motor neuron, right, is going to originate either in our motor cortex, we saw what that was, in the precentral gyrus. We can also see it in a cerebral nucleus or in one of the nuclei found in the brainstem. And that upper motor neuron will then synapse onto another neuron, and that is what we call our lower motor neuron. Now, our lower motor neuron is either going to be located, that cell body is either going to be located in the nucleus for one of our cranial nerves, which is primarily going to be in the brainstem, or, all right, in the anterior horn of the spinal cord. And as a result, it's going to stimulate and excite the muscle. So what's the anterior horn? In case you forgot, it's right here. There's the anterior horn right there. I'll zoom in so you can see it. There you go. There's our anterior horn. All right, so let's talk about our first pathway, which is known as the direct pathway or the pyramidal pathway. So this is basically what is occurring between your brain and your skeletal muscles. Like right now, as I am highlighting certain things on these slides, I am using this pathway here right now. And for those of you that are taking notes or maybe typing something, you too are using this pathway. So we're going to start with our upper motor neurons located in the primary motor cortex. That's in the frontal lobe. That specifically is in the precentral gyrus. And again, remember that motor homunculus, that weird drawing of how your brain, right, views the rest of your body? That's where all that starts, up in that area there. So that primary motor neuron is going to descend, the axon is going to descend through the internal capsule. I'll show you, that's that white matter that's near the thalamus. It's going to descend through the internal capsule and then travel through the cerebral peduncles, which are those anterior structures which were on the front of the midbrain, and descend down through the midbrain into the spinal cord through what we call the cortical spinal tracts, where they'll synapse, these upper motor neurons will synapse on the lower motor neuron in the anterior horn of the spinal cord there. And then that lower motor neuron, whose cell body is in the anterior gray horn, will then exit out of the spinal cord through the anterior roots into the spinal nerve and out to your skeletal muscle. Let's take a picture. Oh, pretty easy, right? Not too difficult. So if you look here, just in general, right? Here's the cell body for our upper motor neuron. And so it is going to start off in our cerebral cortex, or if we're going to be dealing with one of our cranial nerves, it's not shown here, but if we're dealing with one of the cranial nerves, then the upper motor neuron is going to be located, all right, in the brainstem there. So it's going to descend through the internal capsule here. This is this white matter, down through the brainstem, all the way into the spinal cord, where it's going to synapse onto the lower motor neuron in the anterior gray horn. And then that lower motor neuron will exit out of the spinal cord through the anterior root into the spinal nerve and then off to the skeletal muscle somewhere. Okay, so when we're talking about our direct pathway, there's two tracks specifically that we need to discuss. One is the lateral cortical spinal tract, and the other is the anterior cortical spinal tract. I'll go over the lateral first, walk you through the picture, and then we'll come back and do the anterior. All right, so the lateral cortical spinal tract, same type of scenario. Didn't want to do that. All right, whoops, where am I going? All right, the lateral cortical spinal tract. All right, the upper motor neuron is going to originate up in the primary motor cortex. It's going to descend down into the brainstem. Here's an important point, though. It is going to decussate within the medulla oblongata's pyramids, right? And I hope that you remember that from chapter 13. The medulla oblongata's pyramids are those two anterior bulges right in front of the medulla oblongata. And that's where we're going to see these upper motor neuron axons cross over. And so after they decussate, they're going to travel down in the spinal cord through the lateral funiculi. And they're going to descend down to the specific level and then synapse on the lower motor neuron that is located in the anterior horn. And then from there, that lower motor neuron will exit out in and out to the effector, or not organs, but the effector skeletal muscles. So the lateral cortical spinal tract is going to innervate your limb muscles specifically for skilled movements. So you're all familiar with skilled movements, right? Fine finger movements like typing, for example, playing the piano, right? Certain other motions that will involve, all right, some of the larger muscle groups in your extremities too. All right, so the lateral cortical, let me show you the lateral cortical spinal tract. So now we're going to start our story up here in the top. All right, so let's start off with, here is our our upper motor neuron. So it originates up here in the primary motor cortex, descends down through the internal capsule. It will then descend down through the brainstem, through, all right, the cerebral peduncles and the anterior portion of their midbrain. And then once it gets to the medulla oblongata, right, these motor neurons will decussate and cross over. All right. And so they will travel down, once they've decussated, they'll travel down to the appropriate spinal level through the lateral cortical spinal tract here in the lateral funiculus. Remember all this white matter here? That's the lateral funiculus. So it travels down through, and then it'll synapse onto the lower motor neuron. Now this drawing, I don't want to confuse you, you can see that upper motor neuron is synapsing on this little blue fella here. That's an interneuron. Okay, you can't, remember what I said, okay, for these motor tracts, we're going to have at least 2 neurons, you can have more, all right? So this is just showing you, all right, an interneuron involved in this, okay? But for our example, we're just going to go with the upper motor neuron synapses onto the lower motor neuron, whose cell body is in the anterior horn here. And then that lower motor neuron will exit out of the spinal cord through the anterior roots into the spinal nerve, and then out to the skeletal muscles, right, in your limbs for those skilled movements there. All right, the anterior cortical spinal tracts, very similar in how it originates. That upper motor neuron, right, is going to start off in the primary motor cortex, descend down, right? In this case, it's going to travel all the way down into your spinal cord in the anterior funiculi. Right, that's that white matter in front of all that gray matter there. And so it doesn't desiccate in the spinal, excuse me, in the brainstem. It's going to decussate in the spinal cord. And whatever level it decussates at the spinal cord is going to be the level that it exits out of. Okay, so if it decussates and crosses over at T4, then it's going to leave through T4. And so it exits out, excuse me, it doesn't exit out. This is still the upper motor neuron. And then it will synapse either with an interneuron or one of the lower motor neurons there. And that lower motor neuron cell body is located in the anterior gray horn. And so then it exits out of the spinal cord through the anterior roots and then through the spinal nerve, and then it will innervate the axial skeletal muscles. You remember the axial skeletal muscles, right? We just had a test on all that. So think of the lateral cortical spinal tract innervating your extremity muscles, right, the appendicular muscles, and then the anterior cortical spinal tract is going to innervate your axial muscles. So again, you can see, okay, here is the lateral cortical spinal tract, all right, the upper motor neuron. It's going to travel down from the primary motor cortex through the internal capsule into the brainstem. It's going to travel through the cerebral peduncles of the midbrain. In this case, it does not decussate in the medulla oblongata. It stays ipsilateral for now. So the anterior cortical spinal tract descends down to the appropriate level in the spinal cord, and then it will decussate and cross over. And like I said, it will then stimulate an interneuron or the lower motor neuron, and then that lower motor neuron exits out of the spinal cord and goes out to the effector skeletal muscles of the axial muscle group. All right, so that's the cortical spinal tracts. So that's pretty much it for getting into the details of these motor pathways. That was for the direct pathways. The indirect pathways are much more complicated, but we're not going to go through those. But I just want to point them out to you. All right, so we have our direct pathway, which is what we just talked about, and how we're innervating all those muscles in the extremities and in the axial muscles. Right, but now the indirect pathway, this is going to, right, these motor neurons, right, the upper motor neurons start off in the brainstem, right, and then they're going to, again, we're not going to go through this, but they're going to wind up in the spinal cord through a complicated route. But I just want to talk about the lateral pathway and the medial pathway here. Right, the lateral pathway is going to deal with precision movements, all right, of the flexor muscles in your upper and lower extremities there. And it deals with, right, what we call the rubral spinal tracts. And they're going to be seen, the nucleus is going to be seen here in the midbrain. All right, but just keep in mind, this is going to deal with precise movements and also overall just muscle tone. The medial pathway also deals with muscle tone, but in this case, its movements deal with more so, all right, your head and neck, and then your proximal limb muscles, and then the muscles of the trunk. So pretty much it deals with everything that's kind of close to the spine. That's how I like to think of it. Head, neck, trunk, and then the proximal limb muscles, not the distal, but the proximal limb muscles. So there's three, all right, structures that are part, or pathway, or tracts that are part of the medial pathway: the reticular spinal, the tactile spinal, and the vestibular spinal tracts. All right. The reticular spinal, this should sound familiar to you because this is where that reticular formation that we discussed in chapter 13 comes into play. And there's two components to that. There's a motor component and there's a sensory component. All right, this is dealing with the motor component. All right, helps to deal with reflexes when we're involving posture and balance. The tactile spinal tract, we talked about these. Remember our superior and inferior colliculi that have to do with visual reflexes and tracking, and then our the auditory reflexes. So the superior has to do with visual reflexes and visual and tracking, whereas the inferior has to do with auditory reflexes. Turn your head, hearing somebody call your name. Then we have our vestibular spinal tracts. Again, these nuclei will be located in the brainstem, right? But this helps us with balance, equilibrium, when we are doing what we're doing exactly right now, sitting, right? After I'm done teaching, I am going to get up and walk around and stand for a few moments as I eat my protein bar. So I will be relying on the vestibular spinal tracts to help with that. All right, so that brings us to our first clinical view of the night. And we're dealing with treating spinal cord injuries. This hits home for me because I am a Buffalo Bills fan and I cannot remember the life of me, the player that was injured. This was well over a decade ago. I was still living up in New York. He was in a football game and he took a hit and they injured his cervical spinal cord. And so normally what will happen is, they stabilize the patient, they take him to the hospital, and then they quickly work on trying to get the inflammation down, all right? Because if not, okay, and the patient isn't treated quickly and correctly, some of these patients may become paralyzed, unable to move their muscles, not all their muscles, but depends on where the injury is, and they may not be able to actually perceive certain sensations. So normally after the injury, we load people up with steroids. And that helps to reduce the inflammation. But also, right, there was a new technique that was being used years ago. I don't even know if they still use it anymore, but they'll infuse, all right, the spinal canal with ice cold saline. And I'm talking about cold. Because what does an ice pack do? You put an ice pack on your arm if you sustained an injury, helps keep the swelling down. So this ice cold saline, in addition to the steroids, helps to keep that inflammation down, so it keeps pressure off the spinal cord and reduces the damage to the spinal cord. Well, this football player, they did this treatment to him, and he never played football again, nor no one would ever expect him to be able to play again. But he was able to walk, and he did not, he was not paralyzed. So that's a big deal there. Also, early on, we give them antibiotics. We want to try to prevent any type of infection, specifically urinary tract infections and even pulmonary infections. These folks that have spinal cord injuries are notorious for getting pneumonia. And of course, we've been messing around with stem cells And there are some techniques that are being used more so outside the US, in which they're trying to regenerate the damaged cells, specifically the axons. Because remember when we were talking about in chapter 12, how in the central nervous system, if an axon or neuron gets damaged, normally scar tissue forms because the glial cells pretty much prevent the axons in the central nervous system from regenerating, but the neural stem cells can help with that. But again, it's still something that we're working on. We haven't perfected that yet. So just to kind of give you a little bit of an overview here, we'll go in more detail in lab. But if you're looking here at our spinal cord here, you'll notice there's gray matter on the inside, and we have our white matter on the outside. And then we have our posterior and anterior roots. Posterior is where that sensory input comes into the spinal cord, and then the anterior root is where that motor commands exit out of the spinal cord. All right, those roots will meet up with one another and form a spinal nerve. And as you know, spinal nerves are mixed nerves. They carry both sensory and motor information. So our spinal nerve exits out of our vertebral column. You can see it right here. Then we see a little branch here coming off the back. That is called the posterior ramus. Sometimes it's referred to as the dorsal ramus. But this little branch here is going to innervate the deep muscles of your back and the skin on your back. Right? And then from that point on, once the posterior ramus, all right, comes off of our spinal nerve, then we no longer call it a spinal nerve. We call the rest of that structure here the anterior ramus. More on that, not into class today though, okay? We'll get into more detail. I just kind of want you to understand that portion here. Here's our dorsal root or posterior root ganglion, where the cell bodies of our primary neurons sit. And then you'll notice off the anterior portion here, you'll see these two little structures coming off. And those are called the rami communicantes. And they attach to this structure here, right? This is one of our sympathetic trunk ganglion. And our sympathetic trunk ganglion are part of what we call the sympathetic trunk. So if, and again, I'm so sorry that I have to subject you to my horrible drawings, but here is your vertebral column here, all right? So here are all the vertebrae stacked on one another. These lines represent the discs. And on either side of your spine, just outside, you have this structure on either side, and it looks like a string with like these bulges on it. Right? It's on either side of the spine. Well, that's the sympathetic trunk. And those bulges that you see, those are the sympathetic trunk ganglion. So the trunk is the skinny part here, and then the bulges there are what we call these guys, sympathetic trunk ganglion. So the rami communicantes, they're basically the on and off ramps, all right, to the sympathetic trunk ganglion. So it'll have neurons coming in and neurons entering out. And again, when we get to chapter 15, I'll go into more detail about that, but I just kind of wanted to give you a little bit of an introduction to that. All right. So since we're talking about our spinal nerves, all right, we should talk about, all right, dermatomes. Because we discussed how spinal nerves are mixed nerves. They have motor neurons and sensory neurons. So let's talk about what those sensory neurons do. And they create these structures called dermatomes. And basically a dermatome is a specific segment of skin that is going to be supplied by a specific single spinal nerve. The example here talks about the T10 dermatome, which means T10 is the T10 spinal nerve. So the T10 dermatome is normally found around your belly button. T7 is going to be around the nipple line. No, wait, that's T4. Excuse me, I'm jumping all over the place. All right, so I'll show you a map here. Here you can see, let me zoom in. All right, so you see this map here that shows this guy and all these numbers written all over him. Well, what we've done is we've mapped out and we found which spinal nerve is going to supply sensory innervation to specific areas of your body. So here's that T10, for example. That T10 is going to supply this area here around the umbilicus, T4 around the nipple line, T7 is usually around the xiphoid process of your sternum. Right. So what we've done is we've just mapped this all out, which becomes very helpful because if a person comes and says, hey, I cannot feel my pinky and my ring finger, I can't feel it. So we go over here to our map and we're like, oh, pinky, ring finger, oh, C8. So if this is a neurological issue, we may suspect, okay, the C8 spinal nerve, something's going wrong with that. So we have a place to start. So that's basically what those dermatomes are showing us. So it can help us to localize damage, all right, to those spinal nerves if we know that map. Also, you've heard of the term referred pain. You see it all the time when people talk about having a heart attack and they'll have left arm pain, okay? That's referred pain. An example that we see is appendicitis quite frequently. We'll see that pain along the T10 dermatome. Somebody that gets gallbladder pain, sometimes they might notice that they might have right shoulder pain. And that's because with these referred visceral pain, the organs themselves and the skin dermatomes might share, right, the same nerve that goes up towards the central nervous system. It's like if you and I were in a hotel lobby, all right, and we happen to get on the same elevator, all right, that elevator is, we're two completely different people, but that elevator is, we're going to take the same elevator to get to, say we're staying on the same floor, but then we'll go to our respective rooms there, right? So that's what we're going to see here with that referred pain. In some cases, two different structures, all right, the skin segment and that viscera, that organ, might share that same neuron, or not neuron, excuse me, that same nerve. Which brings us to our second clinical view of the evening, which is, I'm sure if any of you have ever had shingles, you know what I'm talking about here, all right? Shingles is the adult version of chickenpox. It's not really, but really what it is it's the same virus though, all right? It's the varicella zoster virus, which causes chickenpox. And you thought, all right, that when you got the vaccine, or if you're much older like myself, that you got chickenpox when you were younger, that you were done with that virus. Like your body eradicated the virus. Nope. Here's what happens. The virus goes and it hangs out and hides in your posterior root ganglion. That's where it stays. And it goes dormant. Doesn't do anything until fast forward to whatever day, and maybe you're under a lot of stress or you get sick and you somehow become immunocompromised. Well, that reactivates the virus. And so that virus will then travel down the sensory axons of that dermatome that the posterior root ganglion was a part of. And so that patient will complain of painful blisters and a rash right along the dermatome. And so it varies on how severe it can be. It can be severely debilitating, or it could just be just an inconvenience there. But most of the time, you give the patient some antiviral medication and some steroids, they're good to go. We have a vaccine now that you can take that helps with that. So you can also do that too. All right, that is shingles. I told you that we were going to talk about reflexes tonight, right? And we are. So I'm going to start talking about the reflexes and then I'll finish up the reflexes in lab. So let's just talk about what a reflex is. Well, you already kind of know what a reflex is because you kind of learned it back in chapter 1 when we were talking about the receptor, control center, and effector. That involves what we call the reflex arc, and we're going to get into that. So a couple characteristics of reflexes. All right, one is they're quick. All right, they're pre-programmed, which means they're always going to be the same. They're involuntary, and it's going to result in the effector, which is going to be a muscle or a gland responding to a stimulus. So here's the thing. In order to have a reflex, you have to have a stimulus. If you don't have a stimulus, you do not have a reflex, okay? So the stimulus is required for that reflex to occur. So it's a quick reflex, which means we only have a few neurons. So if we have 2 neurons in our chain, it'll be a quicker reflex than a reflex that has 3 to 4 neurons. The fewer the neurons, the quicker the reflex will be. They'll always be the same because they're pre-programmed. They are involuntary, and to tell you the truth, a lot of us don't realize that reflex actually occurred until after it happens. That's how fast this thing is, and you won't have conscious perception of it until after the fact, right? And so these reflexes help us to survive, okay? If there's a dangerous stimuli and we need to get away from it, like a hot fire, all right, and you touch it, it's painful, you withdraw, it makes sense because you don't want to go jumping into that thing. So here is your basic component diagram of a reflex arc. So we're going to start off with our receptor, right? So our receptor's here in the skin. In this scenario, you've touched a nail, maybe that was sticking out of something. So that nail is the stimulus that activates the nociceptors, which are your pain receptors. So we know the story, at least I hope we do, okay? That sensory input will travel on our sensory neuron into the spinal nerve, into the spinal cord through the posterior roots, and it will then synapse onto another neuron. In some reflexes, you may only have 2 neurons, and some will have 3 or more. Well, this drawing here shows that our sensory neuron synapses onto an inner neuron, then that inner neuron is going to synapse onto the motor neuron, and then send a motor command signal out to our effector organ. In this case, it's our biceps brachii, pulling your arm away from that sharp pin there that you hurt yourself. I like this picture because it shows our inner neuron has a collateral. So there's a branch coming off the axon, and that collateral travels up to your central nervous system, up to the brain, and it informs your brain of what just happened. Hey, by the way, you touched something that's sharp, and I made sure to pull you away from that. Just thought you should know. All right. So when we're talking about reflexes, we're going to classify some of our reflexes. And here's a couple different classifications. All right, real simple. If it's a spinal reflex, that means that the spinal cord is involved with the reflex. That's our control center. If it is a cranial reflex, that means the brain is going to be the control center or our integration center. Somatic versus visceral has to do with the effector. If it's a somatic reflex, then the effector is the skeletal muscle. All right, that's what we're going to learn this class in Bio 210. If it's a visceral reflex, then it's going to involve cardiac muscle, smooth muscle, or a gland. That's a visceral reflex. And guess what? You're going to learn about the visceral reflexes in Bio 211. So stay tuned for that. A reflex can either be monosynaptic or polysynaptic. Monosynaptic means you have one synapse, so that means you have 2 neurons. A sensory neuron that directly synapses onto the motor neuron. And then a polysynaptic means you have 2 or more synapses, which means you're going to deal with at least 3 neurons. Mono is 1, okay? Poly is many or more. All right, then we have our ipsilateral and contralateral reflexes. If it's ipsilateral, that means the receptor and the effector are on the same side of your body. If it's contralateral, that means the receptor and the effector are on opposite sides. And finally, innate or acquired. Innate, you're born with it, and acquired happens after you're born. All right, so here's a nice picture of our monosynaptic and our polysynaptic reflexes. So you can see here, all right, here's our receptor, here's our sensory neuron, all right, directly synapsing onto the motor neuron. One synapse, which means these reflexes are quicker. Because think about everything that happens at a synapse. You should know this by now. You just had a test on it. All right, our action potential has to get converted into a chemical signal. We have to release the neurotransmitter. That takes time. Right. So if it only happens once, good, that's faster. In our polysynaptic reflexes, we're going to see an interneuron involved here, and that interneuron will play a role, all right, in how that reflex is facilitated. All right, I'm going to stop here for right now, and we will take a break.